I haven't changed the scrubs in the car. With the VBI, you're looking for what? So what does VBI stand for? Especially
Vestibular.
That's where we
I heard one word correct.
Modalities.
Vertebral is correct.
Oh,
Vertebral, not band.
What test did you learn for
we learned the
circulation?
vertebral artery test. But
Okay,
that's not
he's-
VBI.
VBI is vertebral artery.
Yeah, you said say it loud.
Insufficiency.
Okay, all right. Well, okay. So you have again. You know, when you guys have the circle of Willis, and then you have the spinal arteries. They go to the vertebral arteries, and they go to the basilar artery, and it perfuses the whole brain. So the VBI, you're looking for the vertebral basilar insufficiency. So basically, you want to make sure that an individual doesn't have any occlusion within vertebral arteries. Quick story about myself. When I was 27, I was 27, and I was you wouldn't look at it until now, but I was really in shape, and I did a lot of squats, and I had like 405 on the bar, and I was doing a lot of heavy workouts. And one night, about 10 o'clock at night, I woke up out of sleep, and I was kind of like numb on one side. So, you know, when your whole body is kind of numb, and you're worrisome, what can it possibly be at age 27 when you're in really good shape? So I said, let's go to the ER. Went to the ER, they did a bunch of work, they really couldn't find anything. But one thing they were looking for is what's called a vertebral artery dissection. They wanted to make sure that I didn't have a dissection from doing heavy squats, and so that's one way you can develop a dissection. So aside from that, you have the internal carotids that can become occluded, that come off the subclavian, go up. Then you can have vertebral artery occlusion. So you want to make sure that a patient is not going to have that. All right. So to do that, you have to extend, right, and then you want to rotate, okay, and that's going to clamp off that vertebral artery. The Dix-Hallpike is the same position, but you're looking for something different. You're looking for that posterior canal to have symptoms where that crystal is going to drop to the bottom position and induce nystagmus. So now, the key is that gel, the endolymphatic fluid is kind of thick. It has that consistency of cerebrospinal fluid, so it's not watery. It has certain consistency to it. And the crystal is calcium carbonate. So you have to get the crystal to move, and you want it to get it to move, and you want to facilitate it other than just using pure gravity alone. So most people who do the procedure a lot will tell you that the briskness or how fast you do it is semi-important to do. So you always want to instruct to your patient what you're going to do to alleviate fear, okay, and to give them the opportunity to say, no, I don't want to go through it. So what I'm going to do, Antoine, is I'm going to turn your head quickly to the right, and I'm going to lay you back. So from here up is going to be hanging off the table, and I will hold your head in that position so you don't have to worry about holding your head up or working your neck muscles. Is that okay with you?
It's okay.
What you may experience a little bit of dizziness, some sick to your feeling, sensation. If you do, just tell me. But the most important thing I want you to do is to keep your eyes open the whole time. If they close their eyes, you can't see the nystagmus, especially if you're working without the defensive lenses. So they have to keep their eyes open. And what you may experience is that after a certain period of time, the vertigo sensation will go away. Okay? I need a chair. Can I get a stool instead?
Oh, sorry.
Comfortable sitting like that, isn't it? Trying to stick it.
Okay, 1, 2, 3, down. See how fast I went? That's how fast you have to go. So now in this position here, his neck is extended, it's rotated, okay, and I'm looking, this right posterior canal is dependent to gravity. So I'm looking in his eyes, okay, and what I would see is if you see the torsional and upbeating nystagmus, you know, you're going to be thinking that's BPPB. If I see torsional and downbeating nystagmus, that's still BPPB, but it's not the right posterior semicircular canal. What other canal would you think is affected? Which side? Because look at the anterior canal is now to gravity. So I've kept him here long enough. He has no subjective complaints. He has no obvious nystagmus, no torsional nystagmus. And then I would sit him up. Now, if he had it, the treatment for the canalith repositioning treatment or the Epley maneuver is you put him down into the provocative position. You induce the nystagmus. You wait until it fatigues, because the nystagmus will fatigue. So he'll say, I'm spinning, I'm dizzy, I'm going to fall off the table, and they'll say, okay, it went away. So now you have to go about your business in getting that crystal to go through the canal to end up back to that plunger, that's the toilet plunger, that suction. The ampulla is going to suck that back up and bring it back where it lives. So this is the technique. So you hold him here till it fatigues, and then you wait an extra 30 seconds. You rotate him to the other side. Hold him here for 30 seconds. There's no continuation of the vertigo. There's no repeat of the nystagmus. It's just, you know, you're just moving that crystal. So again, his posterior canal was dependent. Now I have to reverse the position of that canal to let the ampulla, which is like a suction, to go. Okay, everybody see that? So now the end position is this. I want you to roll onto your left side. And I want you to point your nose to the floor. And flex your neck a little bit. And stay just like this. So now, here is the posterior canal. It's up. The ampulla, it has that suction effect and it's pulling that back up. But it could take up to 2 minutes. So this is the most important position of it all, is if you don't keep them here long enough, you don't allow that structure, the ampulla, enough time to work to pull that crystal or crystals, could be one or many, back up. Okay? And so there's one important thing that I have to show you when we get to the end position. And what I usually do is I usually take something, a pen, a goniometer, tape measure, whatever I have, and I'll put it on the floor, and I'll say, keep yourself focused, keep your eyes focused on that. And if a patient, you know, obviously if they have a rotator cuff problem, if they have some musculoskeletal problems that they can't assume this position, you may have to modify it a little bit, prop up with a pillow or help position them so they're comfortable. If they have to be here, the treatment's null and void.
What is the difference then between a positive vestibular test?
Oh, and a Dick's Hop Light for a beep, beep, beep. Thank you. Thank you very much. Can I finish this first?
Yeah.
Okay, he's so muscular, he's compressing his brachial plexus. He's getting some numbness and tingling. Yeah, I saw you doing that. I know what's going on. So when he sits up, you want to make sure that he doesn't extend his neck. He has to stay in this semi-flexed position, okay, when he sits up. Otherwise, he'll get very uncomfortable and have a rebound effect. Okay, so when he sit up, my hand is on his head. Bring him like this, and I hold him here, and just stay like this for about 2 minutes. That procedure or technique is positively effective in about 90% of the cases with patients who have BPPV implicating the right posterior semicircular canal or the left anterior canal, or vice versa, the left posterior and the right anterior. Okay? Now, because of the maneuvering technique to get that crystal to go back up, Herdman and her group and those at Bethesda National Hospital, Hopkins and Bethesda worked together for a lot of studies. They would take the soft cervical collars, sometimes the hard ones, and they'd put it on their neck. And they would say, you have to wear that for the next 24 hours because they wanted to make sure that the patients wouldn't look up and look down and dislodge that crystal again, the crystals from the ampulla. They've done trial groups of patients who had it and who did not, and over time they find out that even those who have had the cervical collars, it didn't prevent them from having recurrences. So I put a patient through that restrictive. So instead, what they do now is they give them the verbal cues. So for the next 24 hours, you don't want to look up into the corner parts of the ceiling. You don't want to bend over and tie your shoes. If you can have something or slip-ons, or have somebody tie your shoe, or bring your shoe up and tie it like that. So you want to avoid. You want to avoid looking down in extreme motions with your head. You can do anything you want with horizontal side-to-side movements, just not the extreme movements. I like, when I do this procedure, I have my patients come in before 10 o'clock in the morning so they can do it all day. And then when they sleep at night, for the first night they sleep, I usually say get 2 or 3 pillows and prop yourself up so you're about in, the head of the bed will be elevated probably like 30 to 40 degrees. Or if they have a wedge, I use a wedge. And then the next day they wake up, no precautions. Call them back to the clinic in 1 week, and I look and see if they're positive again for the Dix Hall pipe. If they are, I'm looking at how fast or how aggressive the rotary component in the upping nystagmus is, and I'm looking to see how long it lasts for. So if it's real bad, as soon as you put them down into the position, they'll start to spin. And you can see it with your own eyes a lot of times. And if it lasts 10 seconds, I'll time it and I'll document it. The next time they come in, it may last 2 seconds, so it's minor. You repeat the same epi, call them back a week later. Again, 90% of the time, no more symptoms. They're done. Okay? One interesting fact is that Susan Herdman herself has BPPV. And what she'll tell you is that it's a recurring thing that can happen over time. If you have not had it from a traumatic injury, like a head injury, bump, fall, then everybody's anatomy is a little bit different. Some people don't have that strong suction from the ampulla, and they're more prone to episodes of BPPV. Others have a real strong suction. The only way to know that is you do the technique and see how long it lasts for. Okay? The one thing that I glossed over was, let me have you turn it back around. I'm sorry, come on towards me. So with the VBI, okay. So again, I want to compress the vertebral artery. So if there's an occlusion to begin with, okay, you have the lumen of the artery. The patency might be maybe 50% occluded. When you bring the structure and clamp that down, it's going to close it even more. So then when that happens, blood flow can't go through. If it can't go through, then what symptoms are they going to manifest? Who can tell me? Say it again. Okay. So if I have them come down here, okay, and a minute goes by, or not even a minute, maybe 40 seconds, okay, and I'm looking for BPPV, and if he has BPPV, but he also says to me, I have numbness, I have tingling in my arm, I have to immediately differentiate, is that cervical spine nerve root that's being pinched? Am I in that position? Or is it lack of blood flow? Is he slurring his speech? is he automatically, hey Antoine, you know where you are, you know what year it is, you know why you're here, ask him some cognitive related questions, and if he starts to have problems with that, it's a blood flow related in addition to the peripheral, but hopefully it's not, it's just peripheral nerve. But that's how you go between the two. Okay, does that make sense?
Does the insufficiency and occlusion go hand in hand, or not necessarily? You can have an occlusion without.
You can have an occlusion in any artery. People can have a coronary artery occlusion of 90% stenotic, and safety can happen in the internal carotid or the vertebral artery.
Vertebral-basilar insufficiency is simply describing the phenomenon. Okay, so it's insufficient blood supply to the posterior aspect of the brain.
Okay.
The vertebral artery test is trying to compress the lumen to see if they can bring on those symptoms. It's
the occlusion, for example, right? The vertebral artery test is for the vertebral artery occlusion.
Yes.
Does that go hand in hand with basilar insufficiency, or you can have one or the
No.
other?
It goes hand in hand. Here's why. If you follow the anatomy, I'm sorry, you said, if you follow the anatomy real quick, and you have the spinal cord, and you have the spinal arteries that perfuse the cord, then they go up, and now you have these vertebral arteries. You have two. You have one on each side. They'll go up. If the occlusion is right there, okay, then if there's still enough room to get blood flow to go through to the basilar up to the brain now, and then it perfuses the whole brain that comes around in anastomosis with the front, then you're fine. You're not going to show symptoms. If the occlusion now becomes big enough, then you're going to have symptoms right away. Okay, lower in the spinal arteries, you can have just a spinal artery infarct at that one level. And if you do, then there could be problems with the spinal cord itself. That's something separate that Dr. Walsh will go into much later. So that's the BPPV, that's the Epley maneuver, that's the canal-free positioning technique. Keep in mind that if somebody has the opposite beating, then it's the anterior canal on the other side. Now, what if you want to check the horizontal canal? So I put somebody down in this position, and they have no nausea, no vertigo, no symptoms, but they say every time I turn my head to the right or I kind of tilt like this or look over, I feel dizzy, and I have a little bit of spinning for a while. So I'm thinking, okay, well, maybe not your posterior canal, it could be your horizontal canal. So the way you do that is called the roll test, and it's in your book, and you guys can look through that. Go ahead and put your feet up there, and scoot down a little bit towards the right, and then lay down. So in this position here, his head is already his neck is already at that flexion position. So now what I'm basically looking for is I'm going ahead and I'm turning his head to the side, okay? And again, I'm looking and I'm waiting to see whether his eyes beat down towards the floor. There's geotropic and ageotropic. I'm not going to bother you guys with that, but that just means towards the earth or away from the earth. So with that beating, if he has that, then he's positive for the horizontal canal. It doesn't matter if it's geotropic or ageotropic. The treatment's the same. So you have to treat them by doing the roll test. So, but you do the roll treatment. So the roll test is just to turn their head to the side. Okay? And if you want to check the other side to make sure it's going to be positive, you will see the same thing. Okay? To treat them, you have them, let me sit up. So I'm going to hold them slightly flexed position, turn them, okay? Nystagmus, 30 seconds after it fatigues, all the way to the other side, 30 seconds after it fatigues, and then you go onto your belly. And you come up so your nose is looking down to the floor. And you hold them in that position, and this is the end position, so it's a roll test, they call it. And this is for the horizontal circular canal.
Is Epley the same as cannula repositioning?
Yes, thank you. The cannula repositioning technique is the same as the Epley maneuver.